Good evening, everyone. Myself, Dr. Kiran. The topic given to me is neoadjuvant chemotherapy in bladder cancer. Next slide, please. We know that bladder tumors, up to 60 to 70% of the bladder tumors are superficial, non-muscle invasive bladder cancers. Up to 30% present as muscle invasion bladder cancer, and up to 5 to 10% of the patients are metastatic disease at presentation. Next slide, please. If you want to know what is muscle invasive, as the term itself defines that any tumor invasion which is beyond the lamina propria, that is invasion of the muscularis propria, that is a muscle of the bladder wall, uh, and extending beyond it. Thus, any T2 tumor up to T4A is a candidate for a neoadjuvant therapeutic approach. And also those nodal disease, that is the bladder tumor which has spread to the regional nodes, which is not beyond the common iliac territory, are also candidate for a neoadjuvant therapeutic approach. Next slide, please. Thus, if we see the AJCC TNM stage grouping, we can see that any tumor which is T2A, N0, M0, which constitutes a stage 2 stage, up to a tumor which is up to T4A, N to N3 disease, that is up to the common iliac lymph node, and M0, which is stage 3B, are a candidate for neoadjuvant approach. Next slide, please. Thus, if you want to look at the treatment options for muscle invasive bladder cancer, we can see that it could be a upfront radical resection of the bladder along with a urinary diversion procedure, or the other approach would be a neoadjuvant chemotherapy approach followed by cystectomy. And it has been consistently shown to have an improvement in the overall survival in various in couple of randomized trial and meta-analysis. The other option is a combined modality, that is a tri-modality approach, which are for the patients who are unfit for or not willing for a radical cystectomy procedure and want to retain their native bladder. Next slide, please. Thus, what is the rationale for muscle invasive bladder cancer and why a neoadjuvant therapeutic approach is to be taken? Because we know that up to 25% of the patients of muscle invasive bladder cancer have an occult nodal involvement, and up to 30% of the MIBC have undetected micrometastatic disease at presentation. And there has been a constant improvement in the technical aspects of surgery, diversion, and also in terms of the minimally invasive laparoscopic and robot-assisted cystectomy procedures are feasible and safe. And we know that the phase 3 data and meta-analysis has consistently shown overall survival benefit if neoadjuvant therapy followed by a cystectomy procedure is undertaken. And this approach is also feasible for those patients who are not willing for a cystectomy procedure and want to retain their native bladder. And as we know, any neoadjuvant approach in any advanced tumor allows better drug delivery, and also the patient tolerance is also very good in the upfront setting. Next slide, please. Thus, what is the current algorithm for a patient who presents with muscle invasive bladder cancer? That is T2 to T4A and N plus or N0 or N plus disease. Thus, after a detailed cross-sectional evaluation to ensure that there is no any lymph node which is not beyond the common iliac territory or any distant metastasis, we know that it is a locally advanced bladder tumor, and thus it constitutes at least a stage 2 to stage 3 disease. And if the patient is a candidate for surgery and he is willing to accept a radical cystectomy procedure, he is generally the algorithm is a cisplatin based regimen of up to 3 to 4 cycles, and this is followed by a definitive radical cystectomy procedure. Next slide, please. Thus, what are the options? Although several neoadjuvant therapeutic option has been there, like neoadjuvant, in addition to the neoadjuvant chemotherapy, neoadjuvant radiation, neoadjuvant immunotherapy is the current evolving paradigm. I'll be discussing mainly the chemotherapy approach. Next slide, please. Thus, as far as the neoadjuvant chemotherapy is concerned, we know that bladder tumors are explicitly sensitive to cisplatin agent. Thus, a combination of 2 to 4 drug regimen is commonly used, which is of 3 to 4 week interval per cycle. And although we don't have ideal cisplatin-based regimen, we know that two of the most commonly used regimen, that is the MVAC, which is methotrexate, vinblastine, adriamycin, and cisplatin-based, and also a gemcitabine cisplatin-based regimen. Generally, although we are now moved on to a dose-dense regimen, which is interval compressed, which has moved on from a 28-day cycle to 14-day cycle. And we have seen that although the data is not mature, which has compared a dose-dense MVAC versus a gem cisplatin-based regimen, we know that dose-dense MVAC patients tend to be little superior in terms of the pathological complete response rates, which is a surrogate for a better overall survival. And in addition, neoadjuvant cisplatin-based chemotherapy, as I had previously mentioned, is shown to have a survival benefit of approximately 5% in a meta-analysis. Next slide, please. What are the standard regimens which are used in bladder tumors are the classical MVAC, as I told before, which is a 28-day cycle, versus the dose dense, which is the current standard of care, who are the patients who are cisplatin eligible, preferably less than 65 years, good renal function, and a better performance status of PS1 or less. While a gemcitabine cisplatin is a alternative acceptable regimen, which has shown to be non-inferior to the dose-dense regimen, which is given at a 3 weekly interval up to 4 cycles. And the other regimen which has been seen in randomized trial is CMV. It is also active in this tumor. Next slide, please. Thus, one slide on the renal insufficiency. It is very important to note that those patients with bladder tumor often present with renal, the ureteric obstruction because of the bladder tumor, which is near the ureteric orifices. Thus, it is necessary to relieve such obstruction and see whether there is any improvement in the renal function. If that renal function is improved over time, then we can consider a neoadjuvant approach. But if the renal insufficiency is still persistent, then probably patient is not a candidate for cisplatin, and an alternative agent like a carboplatin or a taxane can be considered, although it is significantly inferior than the cisplatin based. Next slide, please. Just a slide on neoadjuvant immunotherapy. Several phase 1, phase 2 data are upcoming with impressive pathological complete response rates of up to 40%. The current immunotherapeutic agents which are used are atezolizumab, pembrolizumab, and also a combination of dual IO drugs, which is durvalumab with tremelimumab. Very interesting data. Maybe in coming down the line, this fourth pillar of cancer treatment also will show. And thank you so much.